Thank you for watching today. Today I'm talking about the New Zealand Child and Adolescent Asthma Guidelines, which were published at the end of 2017. Before I start, I'd just like to acknowledge the committee that contributed to the writing of the guidelines. Firstly, Professor Ines Asher, who was the chair of the committee, Cheryl Davies and Teresa Demetrio from the Asthma and Respiratory Foundation, who contributed a lot of work, as well as a range of health professionals who all made a very big contribution to the guidelines. The guidelines are largely based on the UK British Thoracic Society asthma guidelines from 2017, with also some influence from the GINA guidelines and the Australian Asthma Handbook. There are also two documents which really contributed to the way we wrote this guideline. The first is the UK National Review of Deaths from 2015, and the second is a review of asthma health literacy in Maori children. So one of the big things that really affected our motivation for the way we wrote these guidelines was a review of asthma deaths in the UK. So in New Zealand we have about 65 to 70 deaths per year from asthma, and that's been fairly static or constant for the last 10 years. A UK National Review of Deaths from 2014 suggested that many of those deaths are preventable. More than 80% of deaths, there was an associated deficiency in acute or chronic care, and nearly half of patients didn't seek help even when they were acutely severely unwell. And one of the other criticisms was that the diagnostic process for establishing a diagnosis of asthma was unclear in many cases. In New Zealand, we have major mortality disparities between ethnic groups. Maori and Pacific Islanders have a much higher mortality rate than non-Maori patients. And there are similar statistics for asthma hospitalisations and the incidence of severe asthma. Despite this disparity in outcomes, there are also differences in treatment. So a study by Sue Kringle showed that when Maori and Pacific Island children present to a doctor with a diagnosis of asthma, they are more likely to receive oral steroids and be treated with nebulizers, which suggests that the treating practitioner thought they had more severe asthma at the time. But despite this, they are less likely to receive inhaled corticosteroids as a preventer. They were less likely to receive asthma education, and they were less likely to be given an action plan. In addition, there are issues with adherence worldwide. Only 30 to 50% of asthma patients are well controlled, and compliance with inhaled corticosteroids runs at about 20 to 30%. So on average, New Zealand asthma patients will pick up 3 preventer inhalers per year instead of the 12 that they should. And that's across all severities, so 34% of patients with uncontrolled asthma use their preventer less than once per week. And adherence has not improved in the last 3 decades. So we've known since the late 80s that inhaled corticosteroids are, as a preventer, really important, but the rate of adherence has remained low through that time with no improvement. The second document that really affected the way we wrote these guidelines, rather than just copying the British Thoracic Society guidelines, was a study of asthma health literacy in Maori children. So this was a study where whānau of children with asthma were interviewed, and they reported not having adequate knowledge about their child's asthma. Less than half of those interviewed understood what asthma was. A third reported they did not know how to seek urgent help. In addition, they reported problems with communication, so they reported not being listened to. They reported not being taught why they were doing things as opposed to what to do, so they were then unable to adapt their child's management. And lastly, they reported being given too much information at once. And the conclusion from this document was that the responsibility for health literacy lies primarily with health professionals. So onto the guideline itself. The guideline is presented as a series of goals introducing different sections, and some examples of those goals are: firstly, all aspects of the health system will support better asthma care, aiming to decrease asthma inequities and improve outcomes. And secondly, that Maori children have asthma outcomes equal to non-Maori and non-Pacific children. and likewise a similar goal for Pacific children. And it's very important to note that we're talking about outcomes here, not just treatment. The guideline presents asthma management as a continuous cycle of monitoring and reassessment, and we've derived this from the GINA guidelines and used the figures from those guidelines. With this, there is a requirement for follow-up and repeated review, and this is a change from episodic healthcare. So we're no longer asking that patients only present when they need a repeat prescription or when they're acutely unwell, but that they have scheduled reviews for their asthma care and monitoring. And this will likely require the use of recall systems in primary care. The next section of the guideline presents 10 top ways that health professionals can help their patients apart from prescribing medication. The first is establishing relationships with their patients to enable trust and mutual decision making. A focus on wellness and avoiding smoke exposure and other environmental effects. Housing is important, as damp and moulding housing and overcrowding are important influences on respiratory health. Addressing inequities in income, and so supporting families in approaching benefits and other assistance is important. Increasing health literacy is essential, and I'll come back to that later in the talk. And there is a big focus on adherence and education, including action plans, access to health care, and when to call an ambulance in acute severe illness. The next section of the guideline looks at diagnosis. So the goal for this section is that all children who have asthma are correctly diagnosed promptly. So the diagnostic process for asthma is a two-step process. The first step is that we get a history consistent with the child having characteristic symptoms based in the absence of another cause. And the second step is assessing response to treatment. This is different from the adult guideline, which is also a two-step process, but it is the characteristic pattern of symptoms, and the second step is assessing lung function and looking for variable obstruction. And that's because many children can't perform lung function because they're simply too young, so we are focused on response to symptoms instead. The likelihood of asthma is increased by typical symptoms such as wheeze, breathlessness, chest tightness and cough occurring in association with typical triggers and being worse at night. Asthma is less likely in the setting of a chronic cough, an isolated cough, the absence of wheeze, or if there's no response to treatment. And there's a table that lists those different features in the guideline. Red flags are really important and something to look out for. So we're really looking for non-asthma causes of symptoms, particularly chronic suppurative lung disease such as bronchiectasis or cystic fibrosis. And we're also looking for fixed airway obstruction such as congenital abnormalities of the airway. So red flags that should be looked for are daily symptoms from birth, which would suggest a fixed airway obstruction. A frequent or daily wet or moist sounding cough, which would suggest a diagnosis such as bronchiectasis or cystic fibrosis. Digital clubbing, chest wall deformity or failure to thrive would likewise suggest another chronic disease such as cystic fibrosis. Heart murmurs would suggest a cardiac cause of wheeze, and asymmetric chest findings or stridor would suggest airway narrowing. Lastly, it's important to check for a family history of unusual chest infections, and also if symptoms are much worse than objective signs or spirometry, then an alternative diagnosis should be considered. Figure 1b in the guideline is the diagnostic process for asthma and wheeze in children 5 to 15 years of age. So it starts with children with typical symptoms. Click. And we would like these children to be labelled as having suspected asthma. And the reason for introducing the diagnosis of suspected asthma is there is a concern that patients are being diagnosed with possible asthma, and that when they are followed up, then that is not being changed and the diagnosis not being confirmed or refuted. So the diagnosis, the label of suspected asthma, is a signal to the next health professional who sees the patient that they need to confirm or refute the response to therapy and the diagnosis of asthma. Children who do not have typical symptoms should be considered for an alternative diagnosis and should have further investigation. The next big question that arises for healthcare professionals is at what age do we diagnose asthma? And the difficulty there is that children under 5 years of age who have wheeze and respond to salbutamol may not go on to have asthma at school age and later in life. So there's been reluctance to label them as having asthma. So these children are labelled as having preschool wheeze. So when we consider a child with preschool wheeze, the diagnostic process really looks at the pattern of symptoms or the frequency of symptoms. So there are two distinct groups. Firstly, those who have very infrequent or rare symptoms, and so those would be the kids who only wheeze when they have a cold or an illness. The second group are those who have frequent wheeze, and there are two groups of those who have wheeze between acute illnesses, so really present with wheeze on a daily or weekly basis, very similar to older children with asthma, but also those children who have very frequent flare-ups of their wheeze. And this is important because only children with regular or frequent wheeze will benefit from inhaled preventers, because those are the only children who have ongoing inflammation in their airways between illnesses. Both groups will respond to bronchodilators when they're acutely unwell. And it's important to remember that the children can swap between groups. So a child that is having frequent wheeze for a few months that you then treat with a preventer may then settle down and become an infrequent wheezer. So the advice in the guideline is that treatment should be re-evaluated and stopped every 3 months in preschoolers. The next diagram looks at children who are preschool. So this is figure 1A in the guideline. So again, we start with typical symptoms, and the first evaluation really is the frequency of wheeze. If the child does not have typical symptoms, they should be considered for an alternate diagnosis. If they have infrequent symptoms, they should only receive as needed care. If they have frequent symptoms, then they should be trialled on a trial of medication preventer, and if they respond to treatment, then we would recommend they be labelled as preschool asthma. And there's two reasons for switching from the label of preschool wheeze to preschool asthma. One is a coding and epidemiological reason, so that it is clear how many children in New Zealand have asthma. And the second is that we're using the label preschool asthma rather than just asthma to differentiate it from those children who have asthma. So the label of preschool asthma is not a lifelong diagnosis and should be re-evaluated after the age of 5 years. It's very important that children in all those groups get regularly reassessed and the diagnosis reconsidered. The next step on the flowchart of reassessment is symptom control. So each time we see a child with asthma, we should be reassessing their control, or their symptom control. So the goal for this section of the guideline is that all children with asthma are assessed for their severity, control and future risk. And that's risk of exacerbations and severe events, as well as risk of adverse events from medications. There is a number of useful tools for this. We're advising the asthma control test in the guideline. That can be easily found online or downloaded from the guideline itself. And that's useful because it's a questionnaire that the parent or child can fill out, and they can do that while they're in the waiting room waiting to see you. It's also very useful from an informatics point of view in that in primary care we can be entering the asthma control test scores of all our asthma patients and monitoring our performance over time. The alternative is to look at the GINA questions, which is a very useful set of questions for assessing how frequently a child has symptoms and whether their asthma is controlled or not. The next goal in the guideline is that the right step of medication in the right device is used for the age and symptoms of the child. So just like all international guidelines for the past couple of decades, we're using a stepwise approach to asthma management. And the goals are to maximise quality of life, or to reduce symptoms as much as possible, to reduce risk of future severe exacerbations, to avoid adverse treatment effects, And we really need to use a stepwise approach to management to do this, stepping up to the right dose that controls symptoms and stepping down when symptoms are controlled to avoid adverse effects. For preschoolers, preventer management is that initially we just start with as-needed salbutamol, and then we look at the pattern of their flare-ups of symptoms. If they have severe flare-ups without frequent symptoms, then we're recommending montelukast as the first-line preventer. But if they have very frequent flare-ups or they have frequent symptoms between flare-ups, then we'd recommend an inhaled corticosteroid. If they remain poorly controlled on a single preventer, then the second line or the second step would be to add the other preventer. So they'd be both on an inhaled corticosteroid and montelukast. At the moment, we recommend against long-acting beta agonists in preschool children. There is simply a lack of evidence of their efficacy in this age group, and there are concerns about the safety, and they are not recommended. So there is a flowchart or a figure in the guideline which shows this stepwise approach, and there's 4 steps, and I'd just like to emphasize, if you reach step 4 and the child is still poorly controlled, then you need to reconsider the diagnosis, perform further investigation, and you're likely to need to refer to secondary care for this. And I'd also like to emphasize the need to reevaluate and step down treatment when the patient is well controlled. For older children, there's an identical flowchart. So again, there's step 1 is as needed salbutamol. Step 2, the first line preventer would be low dose inhaled corticosteroid. If the child remains poorly controlled, you step up to step 3, which would be adding a long-acting beta agonist. As we go into step 4 and step 5, it's very important to be reconsidering the diagnosis and considering referral into secondary care, but also considering referral not just for investigation of the cause of symptoms, but also to consider whether the child's having adverse effects. So children on high-dose inhaled steroids do need to be monitored. There are new options for treatment at step 5 beyond oral corticosteroids, and those include injected medications such as omalizumab and possibly mepolizumab in the near future, and so there is good reason to refer into secondary care for ongoing asthma management. The next goal in the guideline is that for all children with asthma, it should be clear if they should be on an inhaled corticosteroid, and if so, a prescription given and the medication taken. It's very clear that compliance is important for determining risk. So children who are more than 80% compliant have a much lower risk of flare-ups and exacerbations than children who are less compliant. We can assess adherence in a number of ways. The simplest way is just looking at your own prescribing records, but all of us now have access to pharmacy dispensing databases, so we know whether patients are picking up their inhalers or not, and it's often very clear that patients are simply not collecting their inhalers. It is useful to ask patients themselves about their own report, and I find it most useful to ask how often do you forget to take your inhaler rather than how often do you take your inhaler. Electronic monitoring devices have become the gold standard. This does require some investment, but it's relatively cheap, and it's something we may move to in the future. The next goal is that the correct inhaler device is considered and age appropriate. So it's very important to remember that young children can't cooperate with inhaler use, and even slightly older children, they might be cooperative, but they cannot coordinate complex device use. So for children under 2 years, we're recommending a spacer with mask because at this age they can't get a good seal around the mouthpiece. Between 2 and 4 years, they should transition to using the inhaler with a spacer without a mask. And that's important that it happens as soon as the child gets a good seal because that improves lung deposition by about 2/3. However, when the child's having a severe flare-up or exacerbation, then they're going to really struggle to do that, and you should go back to using a mask. From about 5 to 7 years, children can start using a turbuhaler, but if they do this, it's very important to assess that they've got good technique. We recommend against using an MDI puffer on its own, just simply because if you do that, then a lot of the medication gets sprayed on the back of the throat and not into the lungs. but it is possible from about 8 years. However, and despite what we're recommending, which is well-known information, New Zealand children, only 80% of children under 6 currently use a spacer, only 30% of children over 7 use a spacer, and less than 35% are given an action plan, which we regard as a very important part of management. So the solution is to assess patients' inhaler technique, and we recommend that this is done every visit. And it's very important that this is done. Less than 20% of patients report ever having their inhaler technique checked by a health professional. And there are other problems such as that 20 to 50% of health professionals actually have incorrect inhaler technique themselves, and this goes up to 85% in some studies for dry powder devices such as the Turbuhaler. So it is important that you have your own inhaler technique checked or attend workshops or education sessions. Patients' ability to use an inhaler decays over 6 to 8 weeks, so repeated education is necessary, and it can take up to 3 visits for patients to learn how to use a device such as a Turbuhaler correctly. Okay, so the next goal is to identify and address personal, whānau or environmental factors which may be unsettling asthma. So environmental exposures are very important in dealing with asthma control, so assessing smoke exposure around the house, the healthiness of the housing, avoiding allergens if they can be avoided, and also looking at anxiety and psychosocial triggers. So it's very common for patients who have poorly controlled asthma to develop psychosocial problems either from their asthma or psychosocial issues to be causing their symptoms. It's also very important to consider treating such associated conditions as rhinitis, hay fever, obstructive sleep apnea, and reflux. And lastly, also to administer the flu vaccine to prevent severe flare-ups. The next step really is looking at health literacy and education. So the goal from this section of the guideline is to achieve effective self and family education and asthma management. So good asthma education enhances overall health literacy and also enhances self-efficacy. So that's the ability of the patient to really feel and control and manage their own health and asthma. And it's important that education takes time and repeated effort. So we want to avoid that complaint that patients feel like they're being given too much information at once. So the solution is to provide education at every visit and to provide it in small chunks. It's important to incorporate a variety of media, and this can be just simple as involving both verbal information and also written information such as pamphlets. It's important to build a rapport by building partnership, so you can have shared discussion and decision making. And it's important that we all use the share language for better understanding. So patients report it's really difficult when they switch between hospitals and GPs, that everyone's using slightly different words from the same things. So it's important that we all use the same language, so that we use puffers for inhalers, that we use relievers and preventers, and we use simple non-threatening words like flare-ups instead of exacerbation. And it's important to remember the overall goal here is improved self-management, because in the end it is the patient and the family that are going to be managing the asthma. Our next goal is that all children with asthma should be provided with an asthma action plan. Asthma action plans are a great tool for education as an overall education document, but they're really important for advising when to seek urgent help, remembering that patients who die often die at home without seeking help. And the Foundation has developed a really good action plan that is available for download and is very simple to follow and easy to use. Right. The last section in the guideline really looks at acute care, and the goal here is that all children should be managed to avoid life-threatening asthma or death. This is a redrawing of the flowchart that has been around for a while with minimal differences to what has been there previously. The first step is to assess severity and determine whether the patient has moderate, severe or life-threatening features. And the trick really here is that if they have any one life-threatening feature, then they're in the life-threatening category, or if they have any one severe feature, then they're in the severe category, otherwise they're in the moderate category. Mild asthma is not listed as a category, and that's simply because in epidemiological studies, mild asthma is defined as not needing healthcare assistance, so you shouldn't be seeing that. For moderate and severe asthma, the treatment is to provide initial salbutamol and then reassess. If the patient moves into the mild category, then they can go home with ongoing follow-up and care. If they remain severe, then they need to be referred on to secondary care. Oxygen guidelines are given, and also advice on when to refer to hospital and seek urgent help, and when IV or how IV medication should be given. So to summarise, the New Zealand Child and Adolescent Asthma Guidelines are a copy or development of international guidelines, but we felt certain things were lacking, and we've provided an increased emphasis on education and assessing adherence and enhancing health literacy and enhancing self-efficacy. Because we've known how to treat asthma for over 30 years, but we have persistent problems with inequities and poor outcomes. So in order to reduce inequality and improve outcomes, children require time and education, and they require repeated visits and follow-up. Thank you.